CRNA Financial Planning is a sponsor of Beyond the Mask podcast. Investment advice offered through Private Advisor Group. Nothing in this podcast should be construed as investment advice. Plus, did you know listening to our podcast can earn you Class B credits? For details on how to submit, visit the CE credit section at beyondthemaskpodcast.com. Welcome to the Beyond the Mask podcast. This is the Anesthesia Alchemy edition. Join hosts Gary Bridges and Lynn Maxey as they deep dive into today's most important clinical conversations.
Welcome again, listeners, to Anesthesia Alchemy. Lynn and Garry Unplugged. Well, Lynn, today we've got a awesome topic that I am sure traverses people's minds every single day they meet their patient. So I think it's going to be kind of exciting. We're going to get into some pre-anesthesia assessment and those types of things before we even bring our patients back to the operating room. So, Lynn, I'm going to turn it over to you to introduce our guest on this special topic.
Well, I am super excited to introduce Dru Riddle. Dru, I've known about you for a million years. Your face has been all throughout the AANA website, but we have not met face-to-face before, so I'm very excited to get to meet you via Zoom and audio meeting.
Thanks so much for inviting me. It's a pleasure to be here.
Now, where do you work?
I am in Texas, in Fort Worth, and my full-time place of employment is as a professor in the School of Nurse Anesthesia at TCU, Texas Christian University. And I also practice at one of the Baylor Scott and White facilities, one of the large facilities here in Fort Worth. I've been at the same hospital for 20 years now, actually.
Wow.
How long have you been a CRNA?
This is year 25 for me.
Nice.
Yeah.
So you started when you were 12.
I did, yes, obviously. And that's the only way I could possibly look this amazing and have that many years of times in the OR for sure. Yeah, it's a great career. I tell everybody we have an undergraduate nursing club here at TCU that's interested for students that are interested in nurse anesthesia. And I'm the advisor for that club, which is something that just started last year. And we had almost 85 undergrad students just last meeting that are in nursing school right now wanting to become CRNA. So I tell everybody, every young person out there, like, this is the best career. And I'm sure all your listeners think the same thing. It's been fantastic.
Where did you go to school?
I went to undergrad at Virginia Commonwealth University, which is in Richmond, Virginia. And then I did CRNA school at ODU, Old Dominion University, which is in Norfolk, Virginia. So I'm actually originally raised, I was born in Texas, but raised all through elementary, middle, high school, college, grad school, all in Virginia.
That's nice. I love Virginia. What a beautiful state.
It's fantastic. Yeah, we miss it a lot. My in-laws are still there, so we get a chance to get back pretty frequently.
Well, let's jump right into it. Dru, maybe you go ahead and give a little introduction, and while you're doing that, kind of give you something to think about, or certainly our listeners are probably thinking of as like, when you walk into a pre-op or you go to see your patient first thing in the morning or afternoon, sort of what is that mental checklist that we kind of want to walk up to in the first 60 seconds, the things that you don't want to miss. However, there's some things that you have to explore, and maybe you go ahead and kick it off as far as intro, and we'll take it all from there.
Yeah, that's whether you work in an outpatient endoscopy center, doing sedation for colonoscopies, EGDs, you're doing inpatient cabbages and liver transplants, or something in between on that spectrum of, the intensity of maybe the procedure or the anesthetic. One thing is absolutely critical, we know, and that is preoperative assessment. And it's a topic that I think we lose a little bit of, over time you get a little, maybe not complacent, but you get a little comfortable in your practice. Yeah. And, you hit a couple highlight questions, you do a little bit of explanation to the patient, and then off you go. And so I think it's probably something we all need to keep at the forefront a little bit of mind, and maybe, review some of the recent changes in pre-op guidelines, pre-op evaluation. I guess I do have a little bit of an audience here. My soapbox really, is that we,
Yep.
as anesthesia providers, I don't care if you're a CRNA or a physician, we need to stop asking permission to do our jobs.
Right.
And what I mean by that is this notion of preoperative clearance. If I hear pre-op clearance one more time in my practice, somebody is going down, because that implies that someone else, aside from me as the CRNA, is actually doing an evaluation and saying that this patient is ready to go or not for the anesthetic.
Oh,
and
you're not talking about cardiologists or anything like that.
No, of course not. With the ever helpful note of avoid tachycardia, bradycardia, and hypoxemia.
And hypotension.
Well, sure. Well, yeah, that would be lovely as well. But this idea that somehow we need some other specialist to sign off on the physiologic condition of the patient is blatantly incorrect.
Yep.
And we can unpack why and how and when we need consultants pre-op, but fundamentally I think we need to change the mindset of what we're doing there.
Yeah, totally agree.
Can I interject here? So you're saying that we shouldn't need cardiac clearance?
No, I'm saying that we need to stop asking for the term or using the term clearance. What I think we need to start thinking about as CRNAs and our physician colleagues as well is, I know better than anyone else the anesthetic risks for this particular patient.
Right.
I know probably as good, at least as the surgeon, maybe better, the surgical risks for this patient. And I know that if this patient has a comorbid condition, say atherosclerotic heart disease, for example, that I may need to ask a cardiologist this question: is Mr. Jones optimized?
Right.
Not is Mr. Jones cleared for
right.
anesthesia or surgery, but because that's my job.
Right.
The cardiologist's job, or nephrologist or pulmonologist, needs to, in my opinion, be the person to evaluate that particular organ system and say, Mr. Jones would probably benefit from a period of, I don't know, diuresis before he comes in for his elective colon resection. Mrs. Smith probably would benefit from a course of oral steroids to get her inflammatory bowel disease under control before she has X, Y, or Z. So this idea that someone else gives you permission, oh, the patient's cleared for surgery, that's not their role. Their role is to give you input and advice on that particular organ system pathophysiology. And, we may get a note that comes back that says, Mr. Jones has an ejection fraction of X, single digits. He is a cardiac cripple. He is unable to do the following things. And there is nothing that can be done to further optimize him.
Correct.
So then it comes back to you and me as the CRNAs to say, well, Mr. Jones, that means your anesthetic risk is whatever that number is. And there's not a lot I can do to make you better in this acute phase. So do you want to have this done today or at all? And so it gives a little bit more of an informed consent to the patient and reality testing for kind of what's going on. So I'm not implying we don't need consultants pre-op by any stretch of the imagination, but I think we need to reframe the way we ask the question. Don't clear them for surgery. Are they optimized?
Right.
And is there anything that could be done to make their pathology better? Well, and if it can't. And then it comes back to me to ultimately, put that all together with all the other comorbid conditions and, quite frankly, all the anesthetic risk that none of these consultants really know anything about. I mean, how many times have you gotten a note from a cardiologist on someone with moderate to severe aortic stenosis, and it says this patient can only receive a spinal anesthetic? Well, we know that would damn near kill them.
That's right.
Right? But so I don't need you
your
to tell me
suggestion
how
for
to
the
do the
anesthetic.
anesthesia. I
Right.
need you to tell me, is his aortic stenosis optimized or not, for example.
Yeah.
So anyway,
Well, here's another example, and this may segue into something a little bit different. So endocrine. I wouldn't say they optimize. So we can get into all the different oral anti-hypoglycemics, but the insulin therapy, and now our outcomes focus on making sure that we keep hyperglycemia below 150 intraoperatively. And I will tell you, I watch some of these protocols, and you're up to, I think the trigger's let's say 151, I think it is. And we start insulin at 1 unit per hour intravenously. And I'm like thinking to myself, like, I think if I threw a salt shaker into the Gulf of Mexico, that I would have her higher salinity than that 1 unit per hour of insulin. Like it's like, all right, optimize, to your point, Dru, optimize their metabolic condition, and we'll figure out we've got steroids that they might have received. Let's just surgical stress, fight or flight, all these things. And then some of the other stuff that we give will obviously spike up, blood glucose levels and whatnot. So I think your point is well taken, and on that, I mean, when we start looking at GLP-1 inhibitors and how that's transformed in the last, year and a half, 2 years. I mean, there's a lot of, I don't know what you all are doing now, but now we're doing BMPs pre and post-op. You all doing that?
we're not, no, only in a very small subset of patients, but yeah, in fact, those guys, I don't know if everybody saw January of 2026, there's yet another round of recommendations and consensus guidelines from multi-specialty societies around GLP-1s and anesthesia. We can get into all the nuances of those if we need to, but bigger picture, zooming back out, you're exactly right, Gary. I have this diabetic who's, their A1C's been in the 10, 11, 12 range for the past however much time. I don't need the endocrinologist to say, Mr. Bridges over there, he can have surgery. Is he optimized? I think the clear answer is no. And that's not my wheelhouse. I'm not out here optimizing long-term glycemic control. Sure, I can make their blood sugar whatever number you really want it to be intra-op.
Yeah.
But we know the outcome data suggests that doesn't make really a big difference if they have poor long-term glycemic control. So let's get endocrinology to intervene. Give us a recommendation, or perhaps go with that patient, walk them on their journey to getting their A1Cs better controlled before they show back up. And then I take that data and I combine it with all of the other findings from my pre-op evaluation, and I can better quantify risk for my patient.
Exactly.
And I think that, you asked when you open the questioning up, like that first 30 seconds or minute when you're walking up to the patient, like what are you looking for? I mean, I think we all know what we look at, right? There's nothing scarier than rounding the corner in the pre-op area and you stick your head around that corner and you look in and you're like, okay, this is going to be the worst or potentially worst airway I've had in forever, right? Like the glaring obvious things.
Right.
But when I approach a patient, regardless of their planned surgical procedure or the anesthetic I have in mind, it's, have I done everything possible to completely reduce the risk for this patient? And there's always risk. We know this. The healthy 18-year-old for a knee scope that you're going to throw an LMA in could aspirate on you, right? Absolutely. Pretty low risk, but it could happen.
Yep.
But as we begin to escalate comorbid conditions and drive up that preoperative risk, I'm approaching my assessment to say, gosh, is there anything else that can be done or should be done to reduce this risk? And if there's not, then we're good to go. And I probably don't need to waste a lot of time, effort, and money having everybody under the sun, quote unquote, clear the patient for surgery.
Right.
So
Absolutely.
But isn't this pre-op that they see 2 weeks, a month before the surgery? The patients that I've taken care of, I've worked at 2 trauma hospitals. They're so sick. there's nothing right with their systems. How do you address all of the problems? And yes, you can look briefly at the labs and check what their EF is and all those things, but how can you really do right by your patient when they're supposed to be in the operating room in 20 minutes?
Yeah, Lynn, is that's such an important and realistic point, right? Like in an ideal world, we have days and weeks to pour over the chart of every patient, and the reality is they get, it's 7 a.m. and they need to bring them and do a washout of some big, nasty gaping wound in their leg because they got run over by a tractor yesterday. Well, that's a Texas thing, you get kicked by the horse or whatever. And, everything under the sun is wrong with them, to your point. And so I think the answer is, realistically, we can't always optimize everything. And so but to the extent we can, then I think we're obligated to. And if we can't, then we have to go today to the operating room. This patient is not optimized, but is as good as they're going to get. That's a different conversation that I think we should be having with the surgeon and the patient, quite frankly. That in an ideal world, Mr. Smith, we would get your, hypertension and your blood sugars and your creatinine all, teed up a little bit. Unfortunately, if we wait to do that, you're going to end up with a really terrible septic infection from this wound. And so we got to go. But because you've got X, Y, and Z going on, your risk is a little bit higher than the average person coming in here. And I think that we owe that to our patients, right? And quite frankly, to our surgeons as well. We all work with fantastic surgeons, but they tend to be hyper-focused on the surgical issue, whatever that may be. And so to take a step back and say, hey, doc, this is what's going on here, and here's this patient's risk. And, I'm willing to move forward. The patient's willing to move forward, but let's make sure we're all on the same page here, because there's a lot going on that is not as good as it should be.
Now, do you chart any of that conversation?
I do personally. Yes. And I would say not on every ASA 1 or 2, but where I practice as well is a pretty, it's a community hospital, but we're doing liver transplants and
oh my gosh,
kidney transplants
hospital?
And yeah,
That's
it's
incredible.
we're a pretty big. I mean, it's 600 bed big hospital, big tertiary care center for high risk OB, and so we have our share of super sick people as well. And I do chart those kinds of conversations. I've had the opportunity over the years to do a handful of expert witness review for records, primarily defending CRNAs and defending their practices when something has gone awry and somebody decides to press charges. And one of the things I've consistently seen, and those of you listening that have done this kind of work, you know this well, is our charting is woefully under detailed. Yeah. And I'm not saying we need to write a paragraph or 2 or 3 about all of this, but I think putting in a few lines of at least acknowledging that you've evaluated the risk, you estimate that risk to be higher than average, and you shared that with the patient, and he or she is accepting of that. Even, not going to prevent you from getting sued, but if you were to be named, you can have a conversation with the plaintiff's attorney and the plaintiff, if they are around, to say, we had this conversation and it's documented here, and I told you these kinds of things can happen. I'm sorry they did, but here we are. So yeah, short.
And I agree with you. I think charting is extremely important when you have something unusual and the risk for that patient is higher. I try to always chart whatever it is, so that like you said, very briefly, but to say conversation was had with the surgeon and the patient about the comorbidities and the risk with anesthesia and surgery and all of that. So I understand completely.
So Dru, what do you think? What do you think?
Go ahead.
So I know there's a lot of listeners out there. Some are in academic centers, so they're in big, so we have the luxury in those larger centers where patients not all the time, but probably have a better shot at being optimized than some of those freestanding centers that are, turn and burn. And so what would be, I don't know, let's say your top 5 or your top 3, like in those types of scenarios that are outside of academic centers would be like, oh yeah, I've seen this one before and I need to be watching out for it because these are the ones that are let me talk to the proceduralist or the surgeon. It's like, we can't do this. It's too risky. They are not optimized. And to your point, perhaps they are optimized as best you're going to get it, but these are the ones that are the clean kills.
Yeah. So, we look at all of the drivers of post-operative outcomes in terms of bad things happening. And we know the biggest contributor are patient comorbidities. It's not the surgical procedure. It's not our anesthetic choice or technique. Although, the surgical procedure and our anesthetic choice can make or break things. Oh, yeah. But it's really what the patient shows up with. I call it their baggage, right? What did they walk in the door with that over which I have very little control because here we are. So of those comorbidities that tend to be incredibly impactful in terms of driving post-op outcome is preoperative kidney dysfunction. Yeah. And I think we often, it's one of them. I don't know if, it kind of depends on the patient, right? Is this going to be as impactful in this lady as it is in this guy? But pre-op kidney dysfunction, and I think we often, overlook that or maybe don't give it the credit that it deserves. The second is atherosclerotic heart disease. That typical intraoperative or immediately postoperative MI or MENS, myocardial injury after non-cardiac surgery. They didn't have an infarct, but maybe they had some myocardial ischemia. And then all of the sort of pulmonary issues around pulmonary optimization. Now, there's certainly more, but of the 3 that I'm kind of like, all right, what's making my ears perk up a little bit or the hair on my neck stand up a little bit? It's those 3 patients. Now, you combine that with morbid obesity, you combine those conditions with diabetes, et cetera, it just begins to compound things. But, I'm a little bit less concerned about their less than stellar controlled hypothyroidism as I am about their cardiac disease. And one of the interesting facts, I actually teach a class at TCU on this. I'm teaching it this semester. We have an entire semester at the doctoral level for our CRNA learners before they start their residency program about preoperative assessment. I don't know about you, but in CRNA school, I didn't have a freestanding thing on that. I had a lot of talk about it, but we really get into the nuts and bolts of it. And one of the things that I share with my students all the time, and it's an interesting statistic, untreated hypertension, if left untreated, will result in 100% morbidity. It will kill the patient. I'm sorry, mortality. It will kill the patient. We see such ubiquitous hypertension, diabetes, obesity, right? Like that's just, let's start that as the new ASA1 and build from there. Right. Because
but everybody has all of those things.
They
it's
do.
Unbelievable.
They do. But when we think about the physiology of hypertension and autoregulation and shifting where our body can compensate for that longstanding hypertension, I'll tell you what, a poorly controlled hypertensive with some stage 2 or 3 chronic kidney disease scares the hell out of me, more so than the morbidly obese patient with a reasonable exercise tolerance, quite frankly. Even though the airway may be different in those 2 patients, the outcomes are very drastically different. Yeah,
absolutely.
Are you a resident or CRNA looking to transition into independent practice? The AANA and Beyond the Mask are here to help you thrive as your own boss. Introducing the 1099 CRNA Institute, taught by Beyond the Mask host Jeremy Stanley and Sharon Pierce. This comprehensive educational series provides detailed guidance on business structure, legal and tax implications, and financial management, tailored specifically for 1099 CRNAs. Enroll now and earn valuable continuing education credits as you chart a new course in your rewarding career. Visit aana.com/1099 to learn more and take the first step toward your new future.
Getting back to this whole idea on pre-op clearance and optimization, I actually wrote a piece not that long ago, and I haven't yet sent it out for peer review and publication, but I think we overly send people out for preoperative to consultants rather,
right?
Clearance. We can get a pretty good idea of their cardiac function. I hear a lot of people all the time, I want to go have them go to cardiology and get an echo so I can see what their EF is. We have a tool that we can estimate ejection fraction using patient-reported, called the DASI, DAISY scale. And that DASI scale can estimate ejection fraction plus or minus 5% of what I'm going to get from an echo. And so, maybe I need to be screening people a little bit better with some of the newer tools that are non-invasive. They just take a little bit more time, as opposed to, well, let me just send them out real quick and get this echo or get this thing. Because, if it doesn't look burdensome to us, but that patient who now has to go to the cardiologist or then go to the echo center and then get this thing. And by the way, they haven't met their deductible, or they have a co-insurance with their Part B Medicare, and that's a $400 exam plus a $200. And so we've just, we spent $1,000 to get a number. Then we're like, all right, good enough. Let's go.
Right.
Did we really need that?
Right.
And I would say sometimes we don't,
Well, what's the correlation with the DASI and the Mets? If they can't even walk to their mailbox, or they're playing tennis 3 times a week.
Yeah, very big difference. Yeah, so what we know is, I call it moving beyond Mets, and this idea that, can you go up and down a flight of stairs? Can you walk the city block? We know the kind of questions we ask.
Right.
Probably only has a sensitivity of 40 to 50%, meaning half of the people that answer that question, we're not really getting useful data for. We feel good about it. Like, well, they said they could walk up and down the block. Well, how fast are they walking? At what actual cardiac and pulmonary levels of taxing are they doing? Well, we have no idea. They could be, walking. I had a lady one time, I said, can you go up? I have to use phrases like, can you go up and down the aisle at Walmart? And for some of our patients. And she's like, oh, yeah. And her daughter's sitting right there. And she's like, Mom, he probably means walking, not riding on the little electric thing.
Nice.
And I was like, oh, yeah, you know what? Yeah. I didn't think about that. But she can go up and down the aisles just fine.
No
all
problem.
Day until the battery runs out.
You just see her get to the chip section.
Yeah, exactly. But the so I think METS is sort of a good initial screening tool for everyone, right? I even asked my young, seemingly healthy folks, hey, you able to kind of be active and do some things? Can you run? Can you jump? Can you do all that? And, yep. Okay, we're good. Those people that I question, are they either being truthful, or do I really need a little bit more data? DASI is what I would call METS on steroids. And so it asks some very specific questions to the patients in a little bit more detail so that they can say it's just yes or no, just like a METS assessment. But it's, I can't remember. I don't have it pulled up in front of me. I think it's either 11 or 12 questions. There's calculators, online calculators. The patients can self-report it, and actually it'll calculate a DASI score for you, which that score correlates to VO2 max, and it equates to a estimated left ventricular ejection fraction. So
I'm embarrassed to say I've never heard of it.
A lot of people haven't, Lynn, and it's not been out for a really long time, but it has been out for a few years. So DASI stands for the Duke Activity Something Index, and it was developed by our colleagues in the preoperative prehabilitation cardiopulmonary testing lab at Duke. And so it's not perfect. It's certainly not going to give you as much information as an echo, but it's going to give you a lot more information than can you go up and down a flight of stairs, or can you walk a city block? And so for me, in my practice, I use that to then screen for, would they benefit from a cardiology consultation or not? Because, they're giving me kind of this nondescript history. I look at their DASI and it says their EF is in the 60 to 70% range. They don't have other risk factors of atherosclerotic disease. They're not hypertensive. They're not diabetic. Maybe their age would drive me to wanting cardiology to see them. But frankly, I have data, quantitative data to say that's probably a waste of time.
Yeah.
Versus that patient, same scenario, and I do a DASI assessment on them. The scoring in their EF is low or low normal, and I get an impression their exercise tolerance is not so hot. Well, maybe that's the person that should go and make sure they're optimized.
Right.
Yeah.
Dig a little deeper.
Yeah, for sure. And then, point of care ultrasound plays in there as well. Certainly for those folks that have done it well and know how to do it, you can get an estimated idea of what their ejection fraction looks like using a handheld ultrasound in the pre-op area, and with AI now and some of the new overlays that some of these handheld ultrasound companies have, as long as you can get a view, the computer will tell you pretty darn accurately what that EF looks like. So yeah, lots of data that I think we can get and use that we don't need to necessarily burden the patient and the system by sending them out to who knows who, for an evaluation.
Well, I'm kind of excited, hopefully in the next, I don't know, let's say 3 to 5 years, perhaps it'll be 7 years, but not just the point of care ultrasound with the overlays that you referred to, Dru, but our wearables and how we start to use that information now. The companies, or Apple, Google, all those people now have these very elaborate analytics that now will be able to tell you with a lot more prediction accuracy what risk is. And having that little slice for anesthesia optimization is like, you probably shouldn't have your colonoscopy today because,
That's right.
you decompensated in your sleep, for the last 3 out of 5 nights. And I mean, that's going to be really, really critical information as we start to move forward.
There's no doubt. And I think, wearables, I wear one. I have a device that I wear all the time just because I'm a nerd and I love the data that it gives me for working out and sleeping and all of that. But those wearables on the what I'm going to call the front end and the back end, intra-op, we have all the crazy fancy monitors available to us. But someone who, Lynn, to your point earlier, like maybe you see this patient a week or two before surgery, or you see at least their record a week or two before surgery. You look at some of their risk and you think, ugh, this is not the most ideal candidate. Maybe. That doesn't mean that I send them to every consultant in the world, but I bring them to the hospital. I slap this wearable patch on their chest or on their chest and their arm or wherever it goes. And for the next week or two, I collect physiologic data that then goes into an algorithm that says there's a 58% chance of acute decompensation intra-op and post-op, as opposed to there's a 3% chance of that happening. We use, where I practice, we use Epic, and there's a bunch of data which is fantastic if you can figure out how to do it. But, the prediction index for outpatients needing to be hospitalized, that's pretty ubiquitous across a lot of the platforms now. And by gosh, it's really accurate, actually.
Yep.
So
Really?
yeah. And it's looking at some basic demographic kinds of things, the kinds of surgery, the patient's age, a few of their comorbid conditions. There's certain medications if the patient's taking that tend to tick that risk of needing to be admitted up. But it's not super personalized to the patient. And so getting, those individual physiologic data points for, even a few days pre-op may help us in determining, okay, well, they're pretty good to go, or, woo, they are really, really not. And then on the back end, I know we're not necessarily talking about post-op care here, but as part of the continuum, I mean, how many times have you admitted or asked the surgeon to admit a patient to, quote unquote, I need to keep an eye on him overnight? Mm-hmm. There's no other reason other than you just have that sixth sense about
spidey sense.
Your spidey senses that you can't teach, right? I don't know how to teach that to people, but this, like, something ain't right. and I don't want Mima going home and doing bad.
Right.
So I'm gonna keep her overnight. Well, we know actually we do worse keeping Mima overnight because she's disoriented and she doesn't sleep and she's dehydrated and she gets up at 3 a.m. thinking she's in her own house and she falls and then she breaks her hip and then she
Right.
gets a, surgical site infect, blah, blah, blah. So what if on the back end I can do the same thing? I can send Mima home with these wearable devices and then have those data being automatically evaluated with the human overlay, right? The hybrid idea that AI alerts you and I,
Yeah.
hey, this is not looking so hot, and I can intervene before she decompensates. For those of us that have been nurses more than 5 minutes, we used to have those telemetry people that would monitor telemetry for our patients, right? Remember
Right.
that big, that huge big screen of
Yeah.
400 EKG
400
machines.
monitors.
Yes, exactly. And so, they're just looking at EKG rhythms, but Penn actually, University of Pennsylvania has probably the most robust that I know of in the US system. They're doing that right now. They may have 100, 150 patients at home with wearables. And there's a command center essentially that is staffed by usually an attending, like a intensivist, 2 or 3 acute care nurse practitioners, and then some nurses, and they're screening and kind of making these decisions on, is this real? Is it not? Can I pre-dispatch EMS? Can I pre-dispatch a mobile nurse? They're doing actually in some cases where
Wow.
an ICU nurse in a suburban, not an ambulance, but an ICU nurse in the suburban can show up and say, "Hey, Gary, we noticed over the last couple hours things are looking like this is happening. Let's do a quick assessment and
Yeah.
see." I mean, how much money would that save as
Right.
opposed to
Right.
just go to the ER? Because we know that the answer is that's how we solve those things. So, anyway,
We actually have
What monitors are you having the patients wearing to get this data?
I'm personally not because where I practice we don't have access to them. I know, without naming names, but some of the big medical device companies,
Yeah.
if you look in your operating room and see the name of, the company that has your physiologic monitor, they all have
Yeah.
in production, kind of in the testing phase,
Yeah.
these wearables.
So at
Wow.
our conference at ACER and American Society of Enhanced Recovery, we actually had a breakout lab with all those vendors, and they have the wearables. And I'm like, I really like that. And he says, "Do you want one?" I said, "Yeah." And so he gave me the box, and he said, "Well, why do you want?" I said, "I just want to check the data out and see if I'm going to die if I need surgery the next week or two." But you get it, I think it was 7 or 10 days of data, and it automatic uploads. And
Oh my gosh.
Oh, yeah.
I had no idea. I've
Yep.
not heard.
yep, it goes
I'm
through all this
apparently living
AI
in.
risk adjustment, and it does the whole 9 yards. So that next wave that's coming into the marketplace is going to be really very helpful for us, but
Yes.
certainly,
Very good for the patients.
oh, without question, are you optimized? Are you not? And what risk do you have? Right?
And that's knowing that this is coming. I mean, there's no doubt it's already here in certain
It's here.
centers, and it's
Yeah.
going to be pretty much, my assertion is it becomes the standard of care, right? We're probably not going to put the wearable on everyone, but there's probably going to be screening, just like we do for nausea and vomiting risk or sleep apnea risk. If you check the following 8 out of 10 boxes, you're going to have a wearable for a few days or a week or a month or whatever.
Right.
But we fundamentally now need to start thinking about our mindset around that. And am I going to be, as a provider, comfortable and trusting that these data that I'm getting are as useful to me as a note that says patient is cleared for surgery? Because again, I can have all the data in the world. I can use this DASI scale, for example, and evaluate my estimation of the patient's EF or functional status. But, if they don't, if I'm like, well, it's just another piece of paper with some numbers on it, I still want the cardiologist to clear them. Well, there's no point there, right?
Right.
And we all, that diffusion of innovations theory, this idea of there's early adopters, there's laggards at the very end, and most of us are kind of somewhere in the middle. We're going to have to look at the data, read the research, attend the conferences to learn and understand how to trust and really use these data, and recognize, just like all data points, they're not infallible. There's
Right.
still going to be error. We see that all the time in the operating room. You look up and the pulse ox says 0, and they have, they're pink and wide awake, and you haven't
Big
even
and
put them to sleep
warm.
yet, and you're like, oh, well, this probe is bad, or whatever. So,
Really interesting. I've not been exposed to any of that, so that's really fascinating.
well, and there's I think a piece of this pre op assessment, pre-op evaluation that we kind of started with, of like, what are you and I doing when we walk up to the patient?
Right.
And the litany of questions that we all ask, and how we go through the motions of gathering the data we need. I think if we all think about that, is I'm trying to make sure the risk is as reduced as possible, then that will get us to a good point. Secondly, let's stop asking for clearance. Let's try to ask if the patient is optimized. And you and I know if they're not
Right.
optimized, usually. So then it's, I don't think Mr. Jones is optimized. What else could be done? Because that really is in the specialist's wheelhouse, right? I'm not managing chronic blood sugars, for example. But then the third question I think we need to all be considering is, does this patient have evidence that they will benefit from prehabilitation?
Right.
What is their frailty score?
Right.
What is their nutritional status? What is their tolerance for postoperative pain? What is their home situation looking like after this procedure? That there was an article in, I think it was JAMA Surgery, about a month ago. It was a group out of Canada. I think Toronto was leading this study, but they looked at elderly patients in Canada and the burden of surgery. And we all know this and we see this. How many times have we had this patient, we're like, why are we doing this on this 94-year-old, blah, blah, blah?
What's the goal?
Yeah, what's the goal? What are we gaining here? And that was that burden of surgery. It was really interesting what they unpacked in that study. And basically they looked at overall life expectancy, comparing those that did and did not have certain surgeries, and quality of life, etc. And without surprise, sometimes the quality of life and the life expectancy went down, even though the acute whatever was fixed
Yeah.
because of of surgery. And one of the things those folks mentioned in that article, and they did not look at patients that had prehabilitation, but hypothesized that we maybe could change the outcomes if we appropriately prehabilitate folks. So we
Right.
all know about rehab.
Yeah.
You have your total knee, and then you have the physical therapist and your exercises and all of that. But what about on the front end? Can we get you better before surgery?
Right.
And it's not a question of like, okay, I need 7 months to do this. Data say even just a 2 or 3 week
Yep.
bout of physical activity,
Right.
hand ergometry, whatever, can really change your outcome. And I think that is 100% in our wheelhouse as CRNAs to help drive those patients that prehab is going to help, and maybe avoid sending patients when we don't think prehab is going to really give them any meaningful benefit. Again, it's more cost and time and effort on the front end that may be worthless, or at least not really move the needle.
So I'm kind of curious, since you're in education, are programs incorporating stuff like this now? Like this type of topic, I mean, yeah, we go through all the stuff. It's like your hemoglobin. So what's the cutoff points, the sort of the numerical things, but going in and saying like, here's the emerging new data that's coming out. And quite honestly, we need to own it, right? Like
Yep.
this was ASA's stance, almost 10 years ago, is the perioperative home, right?
Yeah.
And that's exactly what they're still working on it, but this is again a space that we need to be sort of the leaders in.
I don't know if it's ubiquitously being taught. I will tell you that if you're a TCU grad, you're going to get it because
yeah.
you're going to have me, and I'm
Right.
going to talk about I'm gonna
Yeah,
talk
no,
about it.
absolutely.
I do think I do think it's being taught. I don't know how and where it's being incorporated into various curricula, but I've been in education a long time now, and I know a lot of the faculty, and I would say that it is likely being addressed or taught or exposed to everyone, before they get out of school. There's that little bit of disconnect where, and we all know this, like what you learn in the classroom and then what happens in reality are
Yeah.
sometimes very divergent,
Yes, very much so.
and so, and I hear this in our students all the time. We're trying to teach them the epitome of what needs to happen, and then the reality is we never meet that level of perfection, and so there's some area in between,
Sure.
and so I think we owe it to our new graduates or residents that are in CRNA programs right now to be practicing evidence-based anesthesia. And so allowing them to have the voice in
Right.
the operating room, in the pre-op area. Hey, Dr. Bridges, I heard this podcast about this DASI thing, and I looked it
Right.
up, and maybe it makes sense. Can we give this a try here?
Right.
And instead of crossing our arms and being, angry and, no, what do you know? You don't even know how to intubate.
Right.
Well, you may not know how to intubate really well.
you can ask a
That's
question.
a skill. Like I can teach you to intubate, but what is DASI? I've never heard of it.
Right.
Teach me, and let's try this and see if
Exactly.
this makes sense for our practice.
Yeah.
Right.
And it
So
gives them the confidence to take the reins.
100%.
Oh, yeah,
Yeah.
absolutely. Well, the other piece of this too is I think this is a great topic, and I don't recall seeing it, whether it fits in EDGE for the educators or Congress. I mean, I've heard enough about dexmedetomidine. I'm pretty sure 10 mics is what you give, whether it's in the nose or in the IV or in a cup or whatever. It's 10 mics, and it works, But, okay, enough with the dexmedetomidine. Let's talk about some stuff that's, we have to define, really, moving forward as a profession.
We have to. And until we can get wearables and AI scrub data
Right.
and those kinds of things, there are definitely some more quantifiable ways
Sure.
of assessing our patient's risk, more than asking a few questions and circling ASA 1 through 5 or ASA, adding an E or not. So harnessing what's currently available, like NSQIP, National
Right.
Quality, Surgical
Registry.
Quality data. It's a huge database with tens of millions of data
yeah.
points. And the NSQIP calculators allow you to enter specific things about your patient. What is their creatinine? What is their this? What is their that?
Their A1C, all of that.
Yeah.
All of that,
All of
yes.
it.
And then it's using, algorithms and statistics behind the scenes to give you an estimate of their overall risk, estimate of their risk of an MI, estimate of their risk of fill in the blank. American College of Surgeons has a surgical risk calculator that is a little bit more geared towards the surgical piece, but I don't know about y'all. I've never done an anesthetic without somebody else doing something to the patient. So
Right.
we need to understand what that surgical risk is. And we know, but do we really
Right.
know all of the nuanced details of what is driving the risk? And so I have anesthesia risk calculators and I have surgery risk calculators, and I kind of fit those together and can come up with a little bit better estimate of risk. And Gary, you asked the question earlier, well, you're in a big academic center or you're in a small rural critical access hospital. That helps me as the CRNA decide if we even do this case
Right.
here.
Exactly.
Is this
Right.
the right facility
Yep.
for this patient, or do we need to escalate this to a more tertiary care kind of center? Or we actually probably can do that. We often think about taking these rural facilities. Oh, we got to get the patients out. Actually, could we keep more of them here if we had more quantifiable
Right.
data to say, actually your risk is reasonably low and your comorbid conditions are well optimized? This seems a little out of what we normally do, but I know our surgeon can do this. I know
Right.
I can do this. So let's allow this patient to stay in their community 10 minutes from home instead of 2 hours and 10 minutes from home, you know?
Yeah,
So I think it
absolutely.
kind of helps us both ways. Who doesn't need to be here, but honestly, who can stay?
Right. Absolutely. And you bring up the surgical risk indicators too, and the importance of us actually needing to know some of that stuff. And well, I'll certainly speak from the academic side is in some of these large centers, we don't have just one surgical team. We have multiple surgical teams. And that conversation around, well, should I be doing your pancreas and or liver and or bowel resection and or whatever in one foul swoop, or should we just do one today, allow you to recover, right, and then come back? And those are important conversations that we need to participate in, because I don't think we appreciate some of the levels of risks that the surgeons actually approach too, and they certainly have heated discussions back and forth when they're trying to collaborate on certain kind of case types. So
for sure. And then in the non-academic settings where, maybe you don't have the liver team, the kidney team, the pancreas team, blah, 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 all trying to do everything together. But maybe you have a general surgeon looking to do a fairly, and I worked in a rural facility in Tennessee, and we had this conversation quite frequently with our surgeon. He was fantastic. But I know you're planning A, B, C, D, E on this list, but really, I don't know that this patient is going to tolerate this 6-hour thing.
Yeah.
Can we solve the patient's problem, at least temporarily, with procedure A and B?
Right.
And can we see if C, D, E, and F need to be done later? Maybe they will need to be done, but can this be, staged?
Right.
And often that allowed us at least to keep that patient in the maybe a little more rural facility, and maybe it could have been done in one foul swoop, 2.5 hours away, but boy, what a burden for the patient. And yeah,
exactly. Yeah. Well, Dru, if there were 3 recommendations that you could give the audience before we kind of wrap things up here, what would those be?
My first recommendation would be, if you don't have, I don't want to know expertise, because I don't know that a lot of us have the expertise yet, but if you haven't begun to dip your toe into point of care ultrasound, I would encourage you to do so. There are innumerable trainings, conferences, many of those being taught by expert CRNAs in this space. But the data that you can get using a handheld ultrasound device at the point of care when you get reasonably comfortable with it, frankly, 30 seconds to a minute or maybe 2 at the most. And I'm thinking about things like point of care ultrasound for airway assessment, for gastric content, gastric antrum scanning, for basic cardiac function. I'm not a cardiologist. I'm not going to do all the fancy measurements, but to get an idea of what does this LV look like? What does this valve look like? It almost becomes qualitative. Is it good or no good?
Right.
Maybe that helps tremendously. And so there's, if your facility doesn't have ultrasound, or you're in an outpatient center that has no need for a big fancy ultrasound, you can get a pretty high quality device that plugs right into your phone or Bluetooth up to your iPad for not a ton of money, quite frankly.
Yeah.
So that would be advice number 1, is get your hands on that ultrasound. Just like a lot of things that we learn, watch a couple of YouTube videos and give it a try. I mean, it's not, it feels, at least for me, I didn't train with ultrasound at all when I was in school. We didn't, maybe nerve stimulator or just anatomic, recognition for our nerve blocks, for example. So it was something I had to help kind of teach myself, and went to a bunch of classes, and I'm by no means the expert at it. The AANA always has, or has typically had, a point of care ultrasound workshop the day before annual Congress, and it's really, really well done. There are certainly others out there. The second piece of advice I would give is If you haven't been keeping up with the preoperative risk assessment tools and data, we focus a lot on techniques intra-op and what new fancy block can I learn, or what new drug is available. All incredibly important, but maybe we're early right now in 2026. Maybe you haven't made a resolution, or if you have, you've already failed your first one. So make a new one. That I'm going to spend 2026 really digging in a little bit to the literature and the data around pre-op evaluation and risk assessment.
Yeah, good one.
And that can be, incorporating new scoring devices or new tools or scales or whatever to kind of help get a better picture of what's going on. And then the last thing I'll end with is stop asking permission to do your job. You're a CRNA. You are the one to clear, quote unquote, clear the patient for surgery. Use your consultants in the way that they are best able to help you, and that is to give you information that you can't obtain on your own on how well optimized and if the patient would benefit from further treatment preoperatively. But asking them to check a box, because look, I'll tell you, and I've seen this, and I've tried to defend CRNAs unsuccessfully, that has had a patient who is clearly not a candidate for a surgical procedure and an anesthetic, who has a single page note from a cardiologist saying this patient is moderate risk and has a check next to cleared for surgery. And the first thing the plaintiff's attorney asks the CRNA on the stand is, Dru, who provided the anesthesia? Well, I did. Was this patient a good candidate for surgery? Well, the cardiologist said they were cleared. Let me go back to my first question. Who provided the anesthesia? It is our responsibility to clear them. We're the ones pushing the propofol or sticking in the spinal. And so please stop asking them for clearance and permission to do what we do. Ask them to help you optimize the patient, and then you get to decide whether the risk is along with your patient, of course, if the risk is acceptable or not.
Excellent.
Those are great points.
Well, thank you, Dru. This was, again, a great podcast, great information, I think very useful for our listeners. And hopefully our listeners will take a lot of the recommendations and the advice that we've discussed today in the podcast and pursue some more additional information for themselves. Well, Lynn, that is a wrap for today. And again, as always, it's a delight to spend some time with you as well as Dru today.
Thank you, sir. And Dru, it was so nice to meet you finally.
Yeah, you as well. Good to see you guys. Thanks so much for having me. It was a pleasure.